pediatrician at UCSF and working on some really interesting issues of early life and COVID. Dr. Zier is one of the medical directors at the Campus for Jewish Living, formerly known as the Jewish Home. And Dr. Jonathan Graf is not just a pretty Rebbitzin, but also a rheumatology professor at UCSF and our MC for this. It came about because we really feel that people should get their information from a trusted source and from friends, and we're so fortunate to have so many experts here in our Share with Israel family who are doing such important work out in the community, and we're so grateful to be able to not only host this conversation, but bring people together to continue to talk about what's important to us and what's on our minds at this kind of crazy time in history that has such important implications for how we treat people and treat each other, treat ourselves, and take care of each other. So I want to thank you all so much for being with us and remind you that the previous 2 sessions have been recorded and are on our website. If you didn't have a chance to hear them, you're welcome to listen to them there. The chat session is open here. If you submitted questions earlier in the week, our doctors will attempt to answer them, and please feel free to ask questions on the chat or to respond, and our doctors will do that as they are able to. So without further ado, I introduced Dr. Jonathan Graf, our host.
So thank you very much, Rabbi, for the privilege of being able to host the 3rd of this series of From the Front Lines, how the COVID epidemic is affecting all of us. I want to echo before we begin something that you said just now. That is the amazing breadth of talent that we have within the Share with Israel community is really, I think, very remarkable. If you look at all of the people who have participated in the previous programs we've had here, all experts in their own right, they have very, very close ties to our very confined Share with Israel community. And it just shows you really how special this place really is. And we want to continue in that tradition tonight with Drs. Flaherman and Zier as well. So I thought I would start tonight. The overall gist for tonight's program came from many of the emails and questions that we've been getting over the past couple of weeks, particularly with respect to how this particular disease, pandemic, is affecting the most vulnerable in our community, namely the elderly and those in nursing homes. But recently, it's kind of ironic. There's been a lot of media and press about how a previously thought to be unaffected part of our population, the youngest, usually vulnerable population to things like the flu and such, has actually turned out to also be affected by COVID as well. And those are our infants and children as well, with these weird syndromes that you may have heard about that have been reported in the press. So I thought this would be a very interesting opportunity to sort of present both ends of the life spectrum and how they are affected by the COVID pandemic, both our most vulnerable elderly population as well as the youngest amongst us too. So I thought I'd start by starting the conversation with you, Dr. Zier. For those of you who don't know, Dr. Zier is the medical director at the formerly known as Jewish Home here in San Francisco. He's in particular involved, the medical director of the short acute care rehab portion of the home, and you can correct me if I'm wrong about that, Dr. Zier. But as a physician at San Francisco General Hospital, I spend a lot of time on the inpatient service, doing my own personal service to the community, where I take care of internal medicine patients, along with the UCSF house staff. And a lot of patients, when they are finished with their hospitalization and ready to be discharged, aren't usually ready to be discharged home. These include patients who have COVID, patients who are here with needing hip replacements, patients who are here with bad pneumonias or heart attacks, and aren't really ready to go home or have enough resources at home to be cared for. And so we often look to place them into skilled nursing facilities, SNFs, we like to call in short, where patients can complete their post-hospital rehabilitation courses before becoming well enough to go home. And I want you to know that amongst the myriad places that are available to send people to in the city, universally, the most highly regarded amongst the professionals in the hospital, this includes our social workers, our physicians and others, nursing staff, is the Jewish home. That's where everybody tries to get their patients to go. And this isn't just for Jewish patients, it's for patients of all walks of life and different religions. And I think it's a tremendous pride amongst our community that this particular institution is held in such high regard. And I mean that sincerely. And it's a particular credit to Dr. Zier, who is one of the medical directors in that institution as well. So with that, Dr. Zier, I'd like to start by asking you a few questions. And that is, let's cut right to the chase before we get to some other issues. I know we're all aware that the Jewish home is one of the acute rehab facilities that has been tasked with caring for COVID positive patients who are being discharged from the hospital and yet aren't ready to go home. So I really wanted to ask you what is the role of the Jewish home and a rehab facility in particular, and how are you able to care for patients in this particular setting, knowing that there are other patients who are so vulnerable to getting COVID within the institution? Are you screening patients when they come in? Do they have to test negative by PCR by the viral testing when they're discharged from the hospital? Or are they admitted to a special quarantine section? Can you talk about a little bit of that to our audience?
Well, first, Jonathan, thank you for your kind words about the Jewish home. Let me begin by saying that in early March, when the COVID epidemic had become preeminent, we were mandated actually by the city of San Francisco to open up a unit at the Jewish home. And at that time, there was pushback by the press and others stating that, why are we allowing COVID positive patients into a facility which has vulnerable patients? We entered into a partnership with UCSF and other hospitals such as Kaiser, providing a special unit at the Jewish home, which is specifically designed to deal with COVID patients who are positive and who are in need of rehabilitation. We felt that this was a mitzvah, that this was a moral obligation that we had. And we set up this unit, which is a totally separate unit, a separate floor, which has a separate entrance to our facility with specifically a staff that is separate from the other parts of our building, and physicians who are also specifically assigned to this unit. And we expected that there would be a surge that would occur. Now, as at this point, we have not had a surge. In fact, we only have 3 COVID patients on a unit designed for 40 patients. The physicians who are taking care of these patients are UCSF and Kaiser physicians specifically assigned to this unit. And as I said before, we have a separate staff. And what I'm most proud of about this unit is that we have had no spread of COVID anywhere in our facility. And we've done a remarkable job in keeping our facility safe. And we have been in partnership with Kaiser and UCSF, who have carefully designed a system for us that is working absolutely perfectly. So in terms of the non-COVID patients, all caregivers and other staff do not go on that floor. All are masked, and we monitor everyone, including staff obviously, who come into our facility every day with a series of questions, temperature check, and we document who comes into the facility and what their vital signs are. In terms of people coming into the facility, we only allow essential visitors. And by that, I mean pretty much families who have hospice patients in the facility. We have discouraged non-essential transfers back to doctor's offices by our residents. And when we do transfer patients back to the hospital, we have a specific system in line to ensure that they are COVID negative before they return to our facility. So we have a less incidence of COVID in our facility than in the general public. We have a very, very safe facility. You also asked me on a personal level about stress for our physicians and our patients. And yes, there's a great amount of stress. In fact, this morning as chief of staff, I led a doctor's meeting, and we had a UCSF infectious disease consultant who was giving us new information that frankly occurs every day. There's so much information that is forthcoming from the CDC, the Public Health of San Francisco, that changes from day to day. And the one thing I want people to know is this is a very difficult virus. This is a situation that is full of a lot of myths, and a situation that we're trying to get out information that is relevant and accurate. But it's very difficult to separate the two in this current environment. I am happy to answer any questions that your participants may have regarding the Jewish home, or what we call the San Francisco Campus for Jewish Living, and any questions you might have regarding our doctors and our patients.
So thanks, Dr. Zier. There are a few questions that have popped up on the chat that sort of get at the question about patients who say don't have COVID, who are in the nursing home. Obviously, there's been the widely reported news that large preponderance of deaths in New Jersey, New York, Washington State, and elsewhere have really befallen residents in nursing home communities, even without those nursing homes actually accepting COVID positive patients from the hospital, which I think really talks to how the Jewish home here, or the Jewish campus of the home, is really on a different level. But that said, a lot of asymptomatic people can carry the virus, both employees and patients coming in and out from being admitted for other reasons to the home. And obviously temperature checks can help. But David Newman wants to know, like, is there any other screening that's ongoing? Are patients being tested regularly, or hospital workers being tested regularly, or is it just really good hygiene that's the most important thing in the home?
Well, I would say that physical distancing and good hygiene, hand washing, etc., masking are imperative, especially in our facility. I would also tell you that we have not had any patients who acquired COVID-19 in our facility. We have 340 patients. So
Wow.
We are emphasizing, as I said before, the physical distancing, the masking, and hand washing. The non-COVID patients clearly are on a separate unit. They do not, none of our staff, none of our physicians who are taking care of COVID patients are even going to other parts of the facility or interacting with any other staff.
So Susan Shapiro asks a fantastic question, and because it has a personal resonance here. I'll read you her question verbatim here on the chat, and then I'll give you my own personal anecdote. So Susan writes, nursing staff at all SNFs are often drawn from caregivers who themselves may be from vulnerable populations, have multiple comorbidities, single parenting, etc. What is being done to support them both physically and psychologically? And now I'll give you my own anecdote. I have a patient of mine who is a caregiver at the home, at this particular facility, who has rheumatoid arthritis. I won't give away her name, obviously, but she's on multiple heavy immunosuppressive medicines as well as having bad arthritis. And so naturally, she's, of course, goes to work knowing that she's particularly vulnerable as well. And so relating to that, to that particular patient's circumstance and this question, how would you answer that?
So as I said before, I think that the physical distancing and other measures such as frequent hand washing do mitigate against the transmission of the virus. But let's be very honest. You can have people who are tested COVID negative and maybe incubating the virus. And I think this points out that this is a very difficult situation that we have with this virus, where we don't have a great deal of information as of yet. So all we can do is follow public health guidelines, CDC guidelines to the letter of the law as best as we can, and hope that we don't have any outbreaks. But I think at the Jewish Home, we are doing exactly that and have done an excellent job. Plus, we do feel we have a moral obligation and a mitzvah that we follow to provide a facility where people who have gotten COVID-19 have a place to go to rehabilitate.
Oh, and kudos for that. I couldn't agree more. I think, you know, a lot of us, like I said, have always held this particular facility in the highest regard in the city. I think you alluded to this, one thing you've done that goes above and beyond the CDC is that you've really forged a very tight relationship with UCSF. I think it's not as if the home itself has a natural, it's not a campus of UCSF that I'm aware of. It's not, and yet this close relationship that you forged with the faculty and infectious disease experts puts you, again, I think it's part of your vision. And I think it's put this particular facility a cut above everywhere else. And I think that's above what the CDC even recommends with that.
Right. We have an excellent relationship with UCSF, and we are in constant contact with the infectious disease consultants. I call them, in fact, I just got off the phone with one of them just before this meeting. And we like to believe that we are very current in our understanding of current guidelines for the COVID-19 outbreak.
So let's speak so we've had several members in our community in just the past several weeks who've been in the hospital. I know this because my wife visits as much as she possibly can or is able to do so. And then when they've been discharged, some of them, of course, have been discharged to nursing facilities, not necessarily the Jewish Home. What advice do you have for our members and others in the public who may have to find themselves going to a high-risk facility with, you know, for their rehabilitation? Should they try to go home as much as they possibly can to finish their rehab course? Should they not fear going to a nursing home for their short-term rehabilitation? And what about members who maybe already live in assisted living facilities or nursing facilities? Should they try to get out of them and move in with their families? What are you recommending to others in our community who live elsewhere?
Okay, there are multiple answers to that.
Yes.
First of all, I can't speak to other nursing facilities. There's been a lot of press regarding outbreaks in other facilities, and I can't speak to the measures that these facilities are utilizing in order to mitigate against the transmission of the virus. It would be best from a psychological standpoint for people after they leave the hospital, whether COVID negative or positive, to go home to a familiar environment and quarantine for at least 14 days. And obviously family members, if their loved one goes to a facility such as ours, are not going to be allowed to visit because we do not allow any visitors other than essential visitors to come into our facility. I can't speak to other facilities, but I'm always a great believer as a geriatrician that patients should return home if there is social and other support with home health services. I think patients do much better at home than they do in an institutional environment, however wonderful that environment may be. In terms of assisted living facilities, I am not sure whether they're going to test every resident and every doctor, which is now being done in the Jewish Home over the next 4 days. And I should have mentioned that to our congregation.
Wow.
So yes, we are going to be 800 people plus about 25 physicians are going to be tested in the next 4 days at the Jewish home. But as to assisted living facilities, I'm not sure what the CDC guidelines are at this point.
So Susan Shapiro asked a simple question, which I could answer, but I'll ask you actually. And she wants to know the difference between a SNF and acute rehab facility. And let me rephrase it, Susan, for you a little bit. They're sort of one and the same thing. A SNF stands for skilled nursing facility, but there is parts of skilled nursing facilities that are used for acute rehabilitation from the hospital with the expectation that the patient will return home. And then there are nursing facilities which are more custodial in their structure, where patients are essentially going to be living their life within. So Dr. Zier, do you want to comment about that for her?
Sure. If you look at the algorithm of going from acute care to a step-down unit, there are different types of step-down units, going from acute rehab to skilled nursing to custodial living to assisted living to board and care. But specifically, an acute rehab unit is a unit which is, number one, covered by care, and number two, requires 3 hours a day of physical therapy and occupational therapy, 3 hours every day. Now, a skilled nursing facility is paid differently than an acute rehab in that you're allowed 100 days of rehab, and that rehab consists of only an hour and a half of PT and OT every day, 5 to 6 days a week. So it is a lesser amount of rehab in a skilled nursing facility than in acute rehab, and the payer source is different.
Let me ask you one final question, and then we'll move on to Dr. Flaherman. Obviously, this pandemic has been isolating for many. I've read articles in the New York Times about singles feeling particularly isolated during this time in their homes. Even myself, with sheltering in place with my family and children, climbing all over us, there is a sense of isolation when we can't see grandma and grandpa and friends and hug and embrace people. But I imagine that must be a particularly difficult thing for residents recovering from their stays in the hospital or longer term residents in nursing homes and nursing facilities. Has the Jewish home done anything to help with that? I imagine the residents may be technically savvy or maybe not. Does it help with Zooming and FaceTiming and setting up events so that people don't necessarily feel quite so isolated, even though they're being isolated to protect their health?
Well, I can only speak to my unit, which is the short-term acute rehabilitation unit. And frankly, most of our patients are much more worried about obtaining physical therapy and occupational therapy than necessarily interacting with their loved ones. Those that we have a robust social service support, and we have 50 or so iPads available on our unit for FaceTime and Zoom meetings and WebEx meetings. And our social service people are very skilled at the technological capability for allow those patients to interact with their loved ones.
That's fantastic. So thank you so much. I really appreciate that, Dr. Zier. Let's move on to Dr. Flaherman here and start by, first, can you tell everyone what it is that you actually do professionally in terms of your research, and how is your research dovetailed into the current pandemic? Because you have a particular interest in pregnant women, of course, and newborns. And so how is that, the natural research interest of yours, evolved in the setting of the current pandemic?
Yes, thank you so much, John. It was fascinating to hear Ben's experiences on the front line in the Jewish home, because so many of the issues, although it's the opposite end of the life spectrum than what I'm seeing, but the issues were so strikingly similar in terms of the social, psychological effects and the anxiety and fear that is related to this pandemic. So I'm a general pediatrician at UCSF, and I do most of my work in the newborn nursery with the babies shortly after they're born and before they go home from the birth hospitalization. I also run a lactation clinic, or I usually run a lactation clinic when it's not a pandemic. And then my research focus is on routine newborn care and how to help healthy newborns grow and develop normally. And one of the things that we immediately noticed with the pandemic in the newborn nursery is that the changes in the health system introduced by the pandemic influenced almost every aspect of the way that we were caring for our patients. So, for example, while often there would be multiple visitors helping a mom in labor, supporting her, distracting her, suddenly we were limited to only one support person. And, labor can go on for a very long time. And it places a large burden on the support partner. And of course, at my hospital, many of our families are giving birth to their first child. So they've never been through anything like this before, and it can be very overwhelming. After birth, suddenly, instead of the sibling being able to come in, say hello, the grandparents, the joy that would be, coming into the room physically from the visitors coming there, instead, not much changed. The family changed location, but they really were on their own in terms of managing their newborn with the help of the staff. And I think that and then of course, once we sent them home, they were still sheltering in place in isolation. And I think overall that experience has a very powerful impact on people. One of the, so I think with a goal to try to understand this and how it's working, how this may impact the overall population of children that are being born during this time, our group started to do a formal research study that we call the Priority Registry, which is stands for the Pregnancy and Coronavirus Outcomes Registry. And this is an attempt to capture as many pregnant and postpartum women across the US as possible with coronavirus. And so far we have about 700 enrolled, and we're targeting about 1,500 to follow them through the end of their pregnancy and through 6 and 12 months of age for the infant, to really capture how coronavirus is shaping the newborn experience across the country. For example, here at UCSF, typically lactation support services are easily available to mothers with a newborn, but we've really struggled to maintain our lactation services because of the need for switching to telehealth and trying to reduce traffic through our clinic. So we're wondering, are these changes reflective of what's happening across the country? And what are the health impacts that may be happening in a variety of settings for mothers and babies who are struggling?
I mean, I remember back to my medical school days in Philadelphia, and one of the things that struck me in a sort of inner city environment was with a lot of, especially with a lot of young, very young parents, teenage parents, mostly, that we were taking care of. I was struck by how I had always assumed naively that giving birth to a child is naturally the happiest moment of one's life, right? It makes sense. But for a lot of people, it's stressful, and there is a significant amount of depression that sort of ensues. And I saw a lot of this as a medical student. That's got to be doubly hard in an era where you get discharged from the hospital and you're immediately quarantined by yourself. Can you speak as your registry following up on these patients shed a little bit of light into that? And if so, what is there available to new mothers out there dealing with the stresses, the lack of sleep, the lack of help that they may be able to get, night nurses or whatever coming into their home, dealing with the stress of having a newborn in their home, and what kind of outcomes might that mean for both the parent and the child?
Yeah, I think this is a very major concern, and I hear people across the country, every meeting or listserv, a meeting I've been to or listserv I've been on has you just hear pediatricians just echoing this concern again and again, that maternal mental health and probably overall family health very much suffering during this pandemic, in particular because of the isolation that you highlight. Layering onto that, communities or families that are struggling with issues like domestic violence, that has become much more pronounced. And I think that is probably has a complex, it's probably happening for a variety of reasons, because not only is there the isolation of the pandemic, but there's also the economic stresses that are happening for people. And there's also lack of mental health services easily available during this time. So I think that is an enormous problem. In our study itself, we are following maternal mental health and using a commonly used screen, the Edinburgh postnatal depression scale, to screen mothers for postpartum depression. But I think across the country, on an immediate basis, we're really going to have to reckon with the consequences of this.
So, wow. I have a colleague, for example, who's been on 4 months of maternity leave that happened to coincide with the pandemic. She's now coming back to work, and for her, she's admitted that it's a psychological stress for her now to be out in the community. She's been a strict quarantiner and has been fine with that, but now that she's out in the community, actually, and as a medical professional, is very, very psychologically concerned about bringing the virus home to her, and has had a lot of trouble adjusting to getting back on the wards in the hospital and such. So it affects people in so many different ways, like you're discussing, like you've described, and we're all trying to help, in any way that we can. Let's talk first a little bit. We'll eventually get to the children's illnesses in a second. We'll sort of end with that. But let's talk about the risk specifically of COVID-19 to pregnant women. What is known about pregnant women acquiring COVID-19, and what is the risk to the baby in particular, to a woman? I know for now we have one patient right now on the L&D floor at the General who is COVID positive. And so what are the special considerations, and what do we know about this in pregnant women?
Yeah, I mean, I think we, in general, we know so little about this illness, but I think that we do know that COVID-19 is easily transmissible from any infected person to any other infected person. So I think it's a real concern with mothers delivering newborns, the potential risk of newborn infection. In general, we with previous infectious agents like H1N1 flu and other public health problems, pregnant women, because they have relatively compromised immune systems, have been especially vulnerable. One good piece of news, I think, for coronavirus is that, as far as we can tell right at the moment, at least from what's been published so far, it doesn't appear that pregnant women are particularly at risk of disease compared to non-pregnant adults, young adults. However, it's since non-pregnant young adults are still at risk, and since pregnant women have to consider their pregnancy and the consequences to their pregnancy of becoming severely ill, it still is a major concern for this population. One of the most common things that I hear mothers talk about is that right now at UCSF Medical Center, we are screening all patients for COVID prior to admission. And in the case of mothers who are expecting to deliver, we're actually trying to do it a few days before their due date so that they come in already knowing their COVID test results. And something I think is a focus of attention among pregnant people is the concern that if they're COVID positive, how is that going to change the management of themselves during their labor and their baby? And I think a problem is that we don't really have good data to tell us how to manage these babies, these mother and baby pairs, when the mother is COVID positive, either is asymptomatic or has mild or moderate symptoms, but doesn't really need medical support for her symptoms. In my work with nurseries across the US, I can safely say that there's almost no two nurseries seem to have a similar policy on this. The CDC currently recommends actually that if a mother has coronavirus, that it be considered to separate her from her baby immediately at birth and for 14 days after. Yeah, and that is an option at UCSF. An option offered by the CDC is what's called co-localization, which means that the mother and baby are kept together in the same, for a mother who's positive for coronavirus, kept together in the same room, but with some kind of screen or curtain between them, with the mother expressing her breast milk or potentially breastfeeding with a mask on while she's breastfeeding. So, so these are concerns that mothers express, mothers have often heard about through media and contact us expressing those concerns.
I've got a study for you. I can't think of a better chance to study the importance of lactation than in this particular instance. If mothers are positive and we presume that they're developing, antibodies, I would love to know what the IgA levels, which are probably extremely protective in some respect, that are secreted in the breast milk from these positive women. It must be a great reason to. I would encourage them all to breastfeed as much as they possibly can.
Yes. I think we're very hopeful that will be the case, but I think there's just so little to guide practice that it's fascinating. If you talk to people around the country, there's every different combination of co-localization versus separation is being used at so many different sites. And I think, there are many places that highlight, as you say, the importance of early breastfeeding for immune protection. And there are, other communities where the fear of the infection itself is so dominant that people are deciding to separate. So it's like a wide variety. And yes, we actually are collecting milk specimens in our study, and we'll be analyzing.
I knew it. You're a good scientist. And blood, I hope. They may have transplacental antibody, IgG that's crossed. I don't know how much. So for those of you who don't know out there, the placenta has receptors on it called the neonatal FC receptors, and antibodies have a portion of the molecule that has something called the FC portion of the molecule. And so there's actually the ability, it's not just that antibodies cross into the placenta on their own, sort of waltz in there, they are actively transported into the placenta. And so across the placenta and into the fetal circulation. So there's a hope that maybe these babies are hyperimmunized as well, passively maybe by the mothers. So what a great study you're doing. Fascinating study.
Check us out. Everybody check us out at priority.ucsf.edu.
I'm going to do that right away. So a couple of more questions. So first let's talk about, I'm going to jump ahead to a couple other questions I was going to ask earlier and then end with some more general pediatric questions. So, so particularly with regard to young children and infants, there have been these reported syndromes, Kawasaki disease or Kawasaki syndrome, purple toes. We've heard neonatal systemic inflammatory type syndromes and things like that. Can you tell a little bit or clarify for the lay audience a little bit what some of these syndromes are, what causes them to affect children? Is it related to the virus itself or the immune system response to the virus? And then afterwards, I can share some of my own personal anecdotes, trials and tribulations in this field from the past.
I mean, I think one of the challenges is, you know, this is all so novel that it's being described in bits and pieces, and a lot of what we know right now is actually just coming out of media reporting rather than necessarily like what we would consider like rigorously reviewed public, you know, medical literature. It's very interesting. So I think, you know, for those who are not familiar with the body's reaction to infectious disease, it's typical for the immune response to the initial infection to generate a non-infectious reaction that happens at a later point in time. And this can be as simple as a patient getting a particular, a child who gets a benign virus having a rash at the conclusion of the
or rheumatic fever, for example. A kid could have a strep throat or a bacterial infection in the skin or something, and then weeks later develop rheumatic fever, right? That's not the bug itself, it's the immune response.
Exactly. And I think the thought is that we may be seeing something like that right now with coronavirus. And this, you know, sometimes as seen, you know, now pediatric multisystem inflammatory disorder may be of that type where it's possible that we're seeing a reaction to the infection that's occurring at a later point in time after even the infection itself has cleared and is generating a variety of consequences to the body. So these appear to be, the characteristic findings of this appear, as far as we can tell, to be different in young children than what's also being seen in teens. But I don't think we yet have enough information to tell us what is the source of this inflammatory cascade and how is this translating into children's health.
So,
but John, I hear you may know more.
well, I spent years as a postdoctoral fellow trying to find the cause of Kawasaki disease, and we were hoping to come up with a diagnostic test. And for those of you who don't know what Kawasaki disease is, it's an inflammatory multi-organ system disease, not unlike what's being seen in kids with COVID-19. That looks like a viral infection. Patients that they get rashes and conjunctivitis and their lips begin to become chapped and swollen. And it looks like any other kid who would get a viral infection, but in a subset of children, and they have very, very high fevers that don't remit. And in a subset of children, they go on to develop inflammation of the blood vessels in the body, and particularly most dangerously in the heart, that can lead to aneurysms of the coronary arteries. And so young kids can actually have heart attacks, and not unfrequently, kids can have sort of silent infections. And then later on in life, in their 20s or 30s, have a heart attack. And when you go to find out why they had a heart attack, you find these giant aneurysms in the coronary arteries, and it was presumed they had Kawasaki. You asked them, he said, yeah, when I was a kid, I had this viral syndrome when I was 3 years old, and you presume it was Kawasaki disease. And there's been evidence in Japan, where it was first reported in the late 1960s, that it spread in waves, epidemic kind of waves, where tens of thousands of kids would get this. And then it sort of died out, and there were sort of smaller epidemics and endemic instances of this entity sort of ever since. So anyway, we were interested in finding the infectious cause. And so we screened the antibodies. I purified antibodies from a host of children who had been diagnosed with Kawasaki disease at the University of California, San Diego. And using some very fancy molecular techniques, but not nearly as fancy as the ones we have today. We found that there were IgA antibodies to a newly reported coronavirus called NL63 back in the early 2000s. And we reported these findings at the American Heart Association meeting, and Kawasaki himself was there and said, wow, this is really impressive. And a group then from Yale were able to molecularly amplify the RNA from the same coronavirus out of the noses from kids who had Kawasaki disease at Yale across the country and publish their findings. And then there was a group of Kawasaki researchers who could not confirm the findings. And so we were unable to further carry on the research and get it published without the molecular methods that are available today we didn't have back then. So I gave up my pursuit and went into more traditional rheumatology and rheumatoid arthritis. And now 15 years later, I wrote an email back to them saying, aha, see, I told you a coronavirus can cause this. And it's different for different kids, but some kids have this virus and certain genetics and other kids have others. So it's a fascinating thing to see this come back now. You know, clearly there are incidents of what we call perniosis developing in kids, like chilblains, where you get sort of frostbite looking lesions on the fingers and toes. So there's something wrong with the blood vessels in areas of the body that are exposed to colder air. We see some kids developing coronary aneurysms and inflammation of the heart vessels, just like in classic Kawasaki disease. So again, this is probably a spectrum on a clinical continuum. And then other kids look like they're systemically ill as well. But I think what's most stunning is that the overwhelming majority of children are relatively asymptomatic or hyposymptomatic with this disease. And there's a very small subset of kids who appear to get these very severe findings. And we don't know if that's genetics, if it's something developmentally different about these children, we don't know. But we rarely see Kawasaki disease in adults, and we rarely see this particular multisystemic kind of manifestation in adults. It looks different in adults and in teenagers, as you pointed out, than it does in young kids. And I think there's a lot that we're going to learn from a research standpoint until then. So even more importantly to me now, so that was me 15 years ago. Fast forward to me 15 years later, I gave up the lab, I got a wife, I got kids, I got religion, as they say. My life has been completely turned around. I don't spend 24 hours a day in the lab anymore. Now I'm concerned. My kids have been locked up at home essentially for 8 or 10 weeks. When can they go back to school? When can they go back to camp? When can they go back to a campground? And I think related to that question is the more underlying mechanistic question for you. I don't know if you know the answer to this, but kids are obviously in general less spared of this disease by and large, but we know they can carry it. Are they robust transmitters of the disease as best we can tell? Or are they carriers, but for whatever reason don't have high titers of the virus and therefore don't spread it as easily as you would think a kid would spread the latest viral disease to their parents and others? What do we know about transmissibility of the virus and kids, and when can they go back to school?
I think that's a critical question for our society, and I think like so much, we definitely don't yet have easy answers. But I do think that there is evidence, at least from China, that children were rarely, in the initial outbreak investigations that they did, children were rarely the index case, meaning that that was rarely the first person to get sick in the household. Was the first person to get sick in any given household was usually not the child. And of course, we have to be cautious in interpreting that data because the testing that was existent at that time may not have fully captured everything that was happening. And certainly since then, there have been situations where a child was an index case bringing coronavirus into a household. But it doesn't seem to be the most common method of transmission as far as we can tell. And it's interesting when we think about that, to think about a disease like, for example, when we think about tuberculosis, tuberculosis is a disease that can have a very severe impact on children. So children can become, even young babies can become quite sick with tuberculosis in endemic areas, but children rarely transmit tuberculosis because they're cough is not able to generate the particle size that's necessary for transmission. And my guess is there's probably someone even on this call right now who actually is more of an expert on this than me. But for example, the public health system won't even investigate the possibility that a child under the age of 5 transmitted tuberculosis. So, and it does appear that coronavirus transmission is related to particle size, because desiccated coronavirus droplets with smaller diameter are less infectious. So, so there is reason to think that children could vary from adults in terms of the particle size that they can generate, and that really might impact the risk of them infecting others. I think thinking about how to get children back to safe socialization is a very complicated question, but I think a really important place to start is that we do know that smaller groups are safer than larger groups. So, for example, if 2 families who have been, sheltering in place for, 2 months now decide that they are going to connect uniquely for socialization opportunities for their children, that's probably, as families start to move out of shelter in place, that's probably a safer choice than sending a child to just, run all around with a group of children or something like that.
Yeah, thanks. I don't know how we're ever going to solve this question unless we go out and do a study that swabs the nose of all of our kids and places them in the room with adults and sees how many of them come down. I mean, it's impossible to answer these questions. To the best of our ability, it's really unknown. But I think there's circumstantial evidence, as you suggest, that perhaps kids maybe aren't the master spreaders that we think they are. That certainly they can spread it, and that a lot of them have it asymptomatically, but maybe it's not the same as maybe, singers in the choir, for example, yes. belting out with their large droplets and, spreading the virus around to their neighbors. So I think it's an excellent point. I sort of want to maybe, and there's an excellent question that was asked here in the chat group, and maybe this would be a good part to sort of begin to wrap up the discussion a little bit. And I think this is for both of you, actually, for Dr. Zier and you as well, since vaccination is important for children and for our older citizens as well. The anti-vaxxer movement is clearly becoming mobilized, I think, right now. It's hard to fathom because a vaccine is truly the only way we'll get around this without trying to deliberately infect everybody. It's the only way I can conceive of this coming under control. But believe it or not, there is a lot of evidence out there that building already that anti-vaxxers are going to claim this is a giant Fauci conspiracy to sort of push vaccinations. How can we begin there? And they're very well organized, whereas the pro-vaccine groups are not. How do we begin to emphasize how important it is, not just for COVID-19, but in general, to vaccinate our children and our most vulnerable elderly patients? I'll start with you, maybe Dr. Zier, and then go to Dr. Flaherman.
Well, I think it's imperative that people do avail themselves of the vaccine. The problem with the anti-vaxxer movement is it's conflated with a lot of other issues. And it's very difficult to unconflate this, so to speak, because of the divisiveness we now have in our country.
Right.
But I think any physician who is honest and knowledgeable would agree that the only way out of this is a vaccine. And it is really unbelievable that people would allow themselves not to avail themselves of a vaccine and inflict harm on other people. But that's unfortunately the world we live in right now. And I'll leave this to Valerie.
There you go, Valerie.
Oh, well, I can easily solve this. I mean,
Yeah.
I agree with everything you both said. It's just a major, major concern that the anti-vaxxer movement is, as far as I can tell, they're not founded on anything. I mean, they're just like, it's just even hard. It's hard to know how to move forward with this kind of thing when the fundamental underpinnings of it are so specious. I mean, I do think, I'm not really speaking as a doctor, but as a person, I think there are two things I can think of that could possibly help. One, I think if it's not, honestly, I'll just be honest, it's not possible for me to really understand the anti-vaxxer perspective. But when I think about that, it inspires me to try to be more broad-minded and understanding of people who have political positions or social opinions that are different, different from mine, and just try to be as open as far in whatever direction as I can until I get to that place where I just really, can't. And then the other thing I think might potentially be helpful would be if there were a way to eliminate private, currently there's a race to find a vaccine that's partially commercially driven. And I think that fuels some of the anti-vaxxer rhetoric. And if we could find a way where there was federal or other, governmental support for this vaccine development and dissemination without the profit centers that there are potentially at this point, I think that would be helpful.
Well, that's great. And again, thanks, Lainey Zena, for the question about anti-vaxxers. I think that's exactly the right answer. I mean, I think if we could be convinced that the federal government, shows the federal government sponsoring this, that's the Department of Defense, the military that will be paying for this and distributing this to everybody and around the world, I think maybe that will go a long way to sort of snuffing out a lot of the far right and far left, really both sides. That there's constituencies on both sides that I think have really been pushing this. Well, we're at 6 o'clock. I can't, this is, again, is another amazing example of the incredible people we have here at Shereth Israel. It's a pleasure to not only get a chance to meet you through Zoom, to get to talk to you and get to know you guys, and it makes me want to get to know both of you even more when we get to resume personal interactions again, hopefully in the near future as well. I'm sorry we didn't get to all of your questions, people who had emailed me before and were writing continuously throughout the chat. I'll try to answer some of these by email later on or refer them elsewhere as well, so you can get your questions answered. But thank you both again so much. This is the third program. All of them have been amazing, and I thank you guys truly for giving us one of the best so far. And with that, Jess?
I want to, oops, so we don't. I want to add my huge thanks to Dr. Flaherman, Dr. Zier, and Dr. Graf for taking a huge amount of time out of really, really busy schedules always, and especially now. I want to thank you for your work that you're doing to advance medicine and thought in the world. I want to thank you particularly for putting this in a Jewish context. And Dr. Zier, you actually said it overtly, but all three of you talked about the role of sort of the Jewish worldview in the way that we are addressing these issues, which are critical in our society today. And I think by looking at this through a Jewish lens and talking about it as our Shereth Israel community, we bring a different perspective to the way that we're just addressing these complicated questions. So thank you for that. Thank you for giving us your amazing children. And children-in-law. Dr. Zier's daughter-in-law is Katie Zier, who is the treasurer of our board of trustees, and she's truly amazing.
She is.
Also married to another doctor who's fabulous. And thank you for lending us your grandchildren, Dr. Zier. Soon, Valerie Flaherman from Year for Wonderful Children. Hopefully we'll get some grandchildren back at Shereth Israel too. So I want to remind everybody that next Wednesday is our annual meeting. If you are a member of Congregation Shereth Israel, you are cordially invited to join us to hear all the things that are going on and to talk about the future of our incredible congregation. If you're not a member, please become a member so that you can register for the annual meeting. And we will pick up with this series from the front line of COVID again in 2 weeks. Dr. Daniel Kraft will be with us, as well as Stephen Schoenfeld, talking about innovations in technology in America and in Israel. So it should be really interesting, interviewed by John.
Relating to COVID, mind you.
Related to, of course.
The cure for COVID, the vaccine stuff, and where they're going to come from Israel and beyond.
Yeah, all about kind of how we're addressing COVID from different angles. So I want to thank you all so much for being with us, and look forward to seeing you many more times this week. Friday night at 6 o'clock, Saturday morning at 9:15, and then Saturday night, that's not this Saturday night, Saturday night, May 30th, as we say goodbye and thank you to Cantor Frommer. So take care, everybody, and thanks so much.
Thank you.